Welcome and thank you for joining today's webinar. I'm Russ Rowan, the Director of Marketing for Autogenous. Our speaker, Dr. Samarani, has prepared a great presentation. I think you all will really enjoy getting to hear from him. We want today's webinar to be as interactive as possible. You'll see that there's a question and answer button on the right side of your screen. Please use it to submit any questions that come up during the presentation. Then at the end of today's webinar, we'll have some time for Dr. Samarani to answer the questions that are submitted. You'll also be emailed a survey after the conclusion of today's presentation. Once you complete that survey and hit the submit button, an email will be sent to you with your CE certificate. So be on the lookout for that survey shortly after the presentation. So now I have the pleasure of introducing a friend of mine, Dr. Rawad Samarani. Dr. Rawad Samarani received his DDS and MSc in Periodontology from the Saint-Joseph University of Beirut, where he currently serves as a part-time lecturer. He has authored several publications, including a textbook chapter focused on guided bone regeneration that was published by Wiley Blackwell. He has delivered numerous lectures and courses worldwide. He also runs a multi-specialty practice in Byblos, Lebanon, which includes a dedicated training facility. He is also a visiting specialist in Dubai, UAE, for advanced implant and surgical procedures. Dr. Samarani is the inventor of the pop-out atraumatic extraction technique, which utilizes the Meisinger-Samarani root elevators, which he recently demonstrated for me and are extremely interesting. With that, Dr. Samarani, very pleased to have you, fortunate to have you. Thank you very much for joining us, and I'll turn it over to you.
Thank you, Russ, for the introduction. Hello, everyone. It's my pleasure to be speaking to you today. And as Russ just said, I'm joining you from Lebanon. So it's a small country, but with a big heart. Because we Lebanese have always had a deep admiration for the United States. And hopefully the days ahead will bring stability to the region. So I'll be able to invite you to visit my country. So let's dive straight into the topic that is going to be about 3D ridge augmentation in the, not the aesthetic zone, in all the areas of the mouth. And we're gonna mainly focus on whether the need for autogenous bone is an absolute necessity, yes or no. So first, before starting, I'd like to talk about some terminology, because we all know about lateral ridge defects, vertical ridge deficiencies, and 3D ridge deficiencies. Like there is 1, 2, and 3 types. For me, all the types of ridge deficiencies are the 3D type, because in every type of defect, we have different components, and we're gonna see that in every case. So every case you approach is gonna be a 3D defect. And also, according to my experience and my perspective of these defects, the GBR, the Guided Bone Regeneration technique, is my preferred choice to treat that. And I'm gonna tell you why. First, let's look at, this is a typical defect. I need to put the full screen so I see better. So this is a typical defect. So most of the time we have a buccal deficiency, a lingual one, and a vertical one. And we know that somehow we have some potential for bone regrowth that goes from 1, 2, 3 up to 5 millimeters, and sometimes even more. And this is in all directions. And since our defect is a 3D defect, and our potential to regrow bone is in all directions, so why don't we always build bone in a 3-dimensional manner? And because that is the case, I prefer to use the membranes, the GBR, where I use a membrane that I can shape it, I trim it, I give it the shape that I like, I give it the shape of a butterfly or the shape of a heart or whatever I want to give the ideal ridge form. Let's look into this case. So this is the thin ridge of barely 2 millimeter dimension. If you want to treat this case and approach it conventionally, you would think maybe I need to build the bone buccally, maybe, and that would be enough. But if you dive deep, you see that it's good to build buccal and also on the lingual. And there is also this vertical component that is always there, that is always missing. Sometimes it is not that important, especially when it is in the back of the mouth. But when it comes to the aesthetic area, it becomes a critically important factor. So this case was treated in this way. It was 3D augmented. And as you can see, we were able to bring this ridge from this volume, this dimension, to this one, and we were able to properly seat an implant. So what have we used in this case? Which technique have we used to have this 3D bone augmentation? Did we use a block? Surely not, because if you put a block, you're going to lose up to 60% of the volume, and mainly you're going to be able to put the block on the buccal aspect. Did we use any ridge splitting? Surely not, because ridge splitting, we can gain some thickness, some volume, but most of the time we lose height. So we gain on one side and we lose on the other. Did we use Khoury technique? Probably the Khoury could have given such results, but I'll tell you my story quickly with the Khoury technique. And for me, the best approach to treat these defects is the membranes, is the use of membranes and biomaterials, which is the GBR technique. So briefly, my story about the Khoury. Khoury is a German guy of Lebanese descent, so I know him very well, and I was influenced at the beginning of my career by his technique, and I put myself into this technique. I applied myself to it, and I was able to master it somehow. This is a case of 2006. For those of you who doesn't know Khoury by definition, it's a technique to 3D build the bone in a three-dimensional manner. So you need to go to the external oblique line and harvest a big chunk of bone where you split it in half, fixate it, and put some autogenous bone shavings in between, and that's what you have. So this is a good outcome relatively, but there's a lot of unspoken things about the Khoury technique. And I've practiced this technique for a while, for several years, and there is always some granulation tissues that grows in between the two bone plates. And sometimes the vertical component is not optimized. So if I'm treating a case in the posterior mandible, it's fine if I don't gain this 1 or 2 millimeters. But if I'm working in an aesthetic area, I need to optimize everything. I need to gain every fraction of a millimeter. That's why I don't feel comfortable using the Khoury 3D ridge bone augmentation technique. And moreover, it's very morbid, it's very aggressive, it's time consuming. You need a lot of bone to build your defect. So here's my reservations concerning this technique that I've used for a while. And I'm not impressed in cases like that. This is a case for a friend of mine. He was showing me his prowess using the Khoury technique. And after doing this very sophisticated approach, he ended up with a ridge that is barely 5 or 6 millimeters in width. I'm not impressed with such outcomes at all, because I need to have every now and then, a 10 millimeter ridge width. And this is really reproducible using a membrane, especially if you're using a titanium reinforced membrane to optimize your outcomes. So back to our defect. So the defect was treated in this manner. We've selected this titanium reinforced membrane, the cytoplast membrane. We trimmed it, positioned it in place, and this is the graft that I like to use, and we're gonna come back very often on this graft. It's a mix between the allograft. It's a mixture between a mineralized and demineralized allograft mixed with some xenograft. So we're gonna talk about this later. And that's it. We were able to bring about this rich volume, which is really important to have this dimension. And let's look at the follow-up, because I've started doing these kind of procedures. I've completely shifted to the GBR technique probably 15 years ago. And since at least 12 or 13 years, I'm using the same materials, the same procedure, the same approach in every single case. And that's why I have a follow-up on a series of cases. So this is one of them. If you look at the stability of the bone, this is over 11 years look at this stability, it's perfectly stable. So let's look into another case, a more challenging case where we have, this is the anterior mandible, where we have the curvature of the arch. And it's very difficult to reconstruct this anatomy, this curve over the arch. How would you be able to do it with a block graft or with a Khoury even, or with any other technique besides using a titanium reinforced membrane, besides using the GBR technique? It's a horseshoe ridge, very curved. And look at the, Steve, I need to hit the play button on the video. Okay. So this is a quick video recording of the procedure. So you localize the mental nerve to show some clinical side of the procedure. So you advance your flaps, you put the tenting screws. These are very important steps. The use of tent screws, especially when the anatomy to reconstruct is a little complex, like this one, like a curvature or like something special. It's not like a 1 or 2 teeth gap in a straight line. So you need those reference, those tent screws that can guide you, the membrane positioning. So otherwise you might collapse a little bit the membrane. So that's the space that we managed to create. And I always put the same bone graft. This is 12 or 13 years in a row using the same bone graft. And you can see the outcome. So I'm going to show you how you close. This is a small slit in the membrane, and then you fold it over and you stabilize it with the Profix screws on the lingual. That gives you a very a good ease of access. The pinning, this is the combination of the pins and the screws. So everything has to be completely stabilized. Everything has to be immobile. Because if you have some mobility in the membrane, you're gonna lose your case. You're gonna miss your case, because the mobility is not good for bone growth. So it's gonna give bad signals, bad signaling to the bone that is growing, and you're not gonna have the bone that you desire. You're gonna have a very thick under the membrane, periosteum type, periosteum-like soft tissue layer. It's called anyhow the soft tissue layer that is underneath the membrane. So this should be, when you uncover your membrane after 9 months, it should be barely 1 millimeter or barely half a millimeter. If you don't have a good stability, you're gonna have a very thick type of tissue under the membrane that will reduce your volume. That's a suturing technique, a suturing point that I have published, where you suture around the adjacent tooth to anchor the flap around the adjacent tooth. This is very important because when you advance your flaps become very mobile, and this mobility creates problems sometimes. Not if you want to close over the incision line, because it's easy here. But if you don't center your flap, you're going to have mucogingival problems on the adjacent teeth. So with this suture, you center your flap around the adjacent tooth, so you don't have like a lateral mobilization of the flap. It's against the conventional wisdom, the conventional approach, where you close first at the incision site and then you care later about the adjacent teeth. So my approach is the total opposite. I center the flap around the adjacent teeth to prevent any mucogingival problems around there, and then I center in the middle because I'm not worried about closing in the middle because I have very loose flaps. Okay, so let's go back let's see the results. This is at 9 months, very nicely recreated curvature of the arch. This is beautiful. This is very hard to achieve with any other technique, any other approach besides the GBR technique. And look at the quality of the bone. This is a big amount of bone volume regenerated. There is always these particles that are on the surface. And this is nothing to be worried about, because on the inside, you're going to have a very solid core. And you can see this is from a sideway view, the curvature of the arch, and how we were able to recreate it and position the implant in a proper way. And so this is to tell you, this is at abutment connection at 3 months approximately after the implant insertion. You can see how the bone is hardening, because sometimes at implant placement, especially when it's a big amount of volume, a big regeneration site, the bone is not very firm. It's not like like what you expect it to be. But the minute you place your implants, the minute you uncover the membrane, you take the membrane off, and you come back after a couple of months, you're going to see this type of hard bone that has formed. It's a very hard and mature bone and very resistant to probe penetration. This is a good test for you to do. So you put your probe and you put some pressure against this new bone. If it doesn't go in, that means it's bone. There's no way else. You don't need a histology to confirm that this is a hard bone. So this is just to illustrate the fact. This is like an extreme case. So from canine to canine, even in smaller edentulous areas where you have only the four incisors, still you have some curvature to recreate, whether in the lower or in the upper. Like in this case, how would you do this angle with a block or with a Khoury plate? It's very difficult. That's why the GBR is always my best choice. Is my only bet. This is the only thing that I do for so many years. So in this case, this is a severe case. Previous implant failures, a lot of bone destruction, and as you can see, the typical standard same GBR every now and then, over and over. And we were able here to recreate the bone and place the implant in a proper way. You can see the amount of bone buckled to the implants, and this is only possible with a GBR. With the Khoury, for example, you might have something nice, beautiful to show on the picture, but not from all angles. Here, if you take all the angles possible, you're going to have a very wide ridge. But I can tell those pictures that they show when they do the Khoury, sometimes they take a very specific angle just to give you the impression that it has a good width. But sometimes, and most of the times, it doesn't have the required width, 8 to 10 millimeter of bone. And that is very critical for bone stability. Excuse me. And look at the stability. Oh, this is over 5 years. This is perfectly stable. This is very beautiful, very nice stability. And this is a proof that this is a living bone. It's being remodeled. There's a turnover around these implants, and everything is stable, like a natural bone. So, do we do GBR with the PTFE membrane exclusively? Of course not. The PTFE are only used when there's a big defect to tackle. I'm not going to say lateral or vertical, because every time is a 3D ridge defect. When it's big, when it's critical, when you want to optimize your outcome, when you don't want to miss your case, you use PTFE, because collagen is very good, but there's a factor of unpredictability with every collagen membrane case. And you're going to see it's never as predictable as PTFE. If I have an aesthetic case, and I need to promise the patient the best, I use PTFE, because this is always predictable. You never miss your point. So let's see what about the collagen. And while detailing a little bit about my approach with the collagen, I'm going to show a little bit of history, a little bit of literature. What can we expect with the collagen membrane? Because, with PTFE, there's no limit. So the minute you stabilize your membrane, everything is stable. You have a good graft. You have everything right in place. You're going to have a very good outcome. But in collagen, it's not the case. So what can we expect with a GBR using a collagen membrane? The data is a little bit confusing, because we have different types of collagen. We have the native type of collagen. We have the cross-link type, different types of cross-linking, different types of studies. And very few studies have the power to really demonstrate a clear-cut difference. Anyhow, no study exists that compares in a very methodological way in a randomized clinical trial the difference or the equality or the superiority of one of the other. It does not exist in the literature. We have a lot of some case series, some systematic reviews based on case series. So the number that we have with collagen membrane, the average is 3.6 millimeter. So is 3.6 millimeter good enough for you? Maybe in some cases. If you're starting with a 5 or 6 millimeter ridge, 3.6 would make a good change, a serious improvement. If you're starting with a 2 millimeter, 3.6 might be a little deceiving, a little less than what you would need. But you need to keep in mind that this is only an average. So we have in the literature some minimum numbers that are as low as 2.6 millimeters, and some others that are as high as 5.7, like the paper from Istvan Urban. So where is the truth? So we have to bear in mind that using a collagen membrane historically was like conceived for extraction socket defect, for small dehiscence type defects around implants. If you have like a 1 or 2 threads that are exposed, you use a collagen membrane. But they were never intended to really rebuild the ridge, like ridge augmentation. To the point that the Bern School, the Boozer group in Switzerland, this is probably one of the most serious people who have worked on the collagen membrane. So they defined a protocol. If you want to use the collagen and not the PTFE, you need to use a block graft underneath to give volume, to give stability under this collagen membrane. And they like to use a native collagen membrane. And probably this protocol is one of the most researched, they have the longest follow-up. So this is a serious approach, but it tells us something that GBR with a collagen membrane, at least with a native collagen membrane, you cannot get the 5 and 6 millimeters. And it was like that until we had the publication of Istvan Urban. So Istvan came in around 2013 and he said, hey guys, you don't need this block underneath. I have another way to fix it. I have another way to do it. I can give you 5, even more, even 6, 7 millimeter with a collagen membrane without the block. I don't need your block. I just need to stabilize everything like crazy. And he termed this approach the sausage technique. So stability proved to be key here. And it proved to be a very good technique. And it's adopted now everywhere in the world. So everyone knows about the sausage technique that gave the numbers even better than the approach where we're using blocks and collagen. So this is in terms like a historical perspective, and I'd like to talk here about my personal relationship, my personal encounter with Istvan. In 2011, I invited him personally to Lebanon. So he came to Lebanon. It was a very interesting presentation he gave and a course. So I was at the Lebanese Society of Perio, and in 2011, he already had a very rich material to present, and this was 2 years before his landmark publication. So I was really impressed by what he proposed, what he showed us. So he's spectacular. He's a very good clinician. He's an excellent clinician. He's a great speaker, and he defined what he has called later the sausage technique. So I liked it, and I decided to adopt it and to do like him, because I was very impressed, but with some reservations, because Istvan, he preached a lot for the native collagen membrane, and he talked a lot about the autogenous bone and mixing the autogenous with a xenograft. So I used to like the cross-linked. I'm a cross-linked guy because, in the membrane world, you have the native collagen people and the cross-linked people. So I belong to the other party, the cross-link, because I believe that cross-linking increases, because it increases the barrier function of the membrane. It gives more chance, more time for bone to mature, and you're going to have more bone at the end. But this is only an assumption because there's no single study that proves the equivalence or the superiority of one over the other. So because I'm an adept of cross-linked collagen membrane, I decided to do the sausage technique of urban, but with a cross-linked membrane. And I've decided to use, instead of the autogenous bone, I came to this decision probably 2 years later. Instead of the autogenous bone, I decided to use an allograft, a very special allograft. I'm going to tell you which one is it. And I've decided also to add some 10 screws. And I came with time to give a name to my modification of the East Van Urban approach. I called it the reverse sausage technique because I've reversed some elements. Instead of the native collagen, I'm using the crosslink. Instead of the autogenous, I'm using the allograft. So let's see how it goes. So the cross-link membrane that I used to like, and that I was an adept of, was precisely the RTM collagen from Osteogenics, because I was a fan of this membrane. It was giving me great results, and I saw no reason to change according to Van Urban's recipe. Even he's great; he's giving very good results, but I saw no reason to change. So I kept my cytoplast RTM collagen membrane in the equation. So, and I started using it. And I'm going to tell you why I decided to switch the autogenous bone with this type of bone, because I was using the Anchor from Osteogenics, the 70-30. It's a mixture between a DFDBA and an FDBA. It's a 70% mineralized and 30% demineralized. And I was already using for other indication. I was like exploring. This was a new product, and I was exploring it. And this product, I was like encouraged by those people. So this is the group of Massimo Simeon. You know, Simeon is probably the godfather of GBR. So they're based in Milan, in Italy. And they have this very interesting paper a couple of years back. They were talking about this mixture, like it's like the magic mixture. And they had a very serious paper about it, a very nice publication that I knew about. And when I saw Anchor, I thought maybe I need to try it. And I started using Anchor in the sinus. And I was surprised. Look at that. Look at that. This is only the Anchor. And this is after 7 months. You see a complete healing, a complete bone formation, a complete corticalization of the window. Something that I've never seen with a xenograft or with any other biomaterial except the autogenous bone. This is a case of autogenous bone because I was an adept of Khoury technique. I was an adept of autogenous bone before. And now I've changed. So this is back in the days, 2006, I was using autogenous bone everywhere in the sinus. So if you use autogenous bone, you collect some bone from the ramus, you put it in the sinus, you're going to have that, a complete corticalization of the sinus. And none of that happens when you're using xenograft, for example. And I saw that this Anchor is behaving like an autogenous bone. And I was like completely surprised, and I like this product. And I kept using it. This is a case of xenograft for your info. You see, so xenograft, you put the implants, they succeed, it's fine. We have a lot of trials. It's okay, but it's different. The clinical healing, the feeling is different. You see those particles, you put a probe, it goes in sometimes 4 or 5 millimeters. You don't see that with an allograft. Even despite the fact that we don't have any clinical paper or histology that confirms the superiority in a clear-cut manner of an allograft. But I can tell you from a pure clinical perspective, there is a difference. Allografts are better than xenografts, and this is something that I have experienced many times over. So this is a socket preservation. So look at the quality of bone that you get in a socket preservation. And I was surprised because with xenograft, you don't get that. You get a lot of particles. And it was demonstrated that xenograft in a socket delays healing. It maintains the volume, but it delays bone formation. Unexpectedly, very shocking to so many clinicians. You put a xenograft, you delay healing. With an allograft, the outcome is different. So, and I've tested it in some GBR cases. So this is like a critical case, aesthetic central. I put a 10 screw, I use my RTM, My anchor, beautiful, nicely regenerated. You can see beautiful outcome, beautiful outcome. So this product looked like a miracle for me until I started experiencing some complications, some problems. And the problems, the alarm signals is some bone remodeling, some bone loss, some bone volume loss at implant placement or later. And you know, many people, many expert clinicians, they talk about this fact that allograft, they do remodel more. There's more resorption that takes place with this material. But believe it or not, I know the literature. We don't have a single evidence. So we have some papers, they just like barely talk about it when they're discussing their outcome. But we don't have proof, like a solid proof. And I have experienced that. So when it comes to big bone augmentation, if you're using allografts, whatever the type, you're gonna lose some volume. This is a very big augmentation, the posterior mandible. This is one of the most outstanding cases where it was telling me allograft, they remodel a little more than what you used to do. So I managed to recreate the ridge, 7 millimeter in vertical, 3D, and this is an abutment connection. So part of this bone has like saucered, disappeared. And it happens with allografts, not every time, not in all the cases. Probably the bigger the case, the more challenging the healing, the less is the healing potential of the patient, you might encounter these problems. So at one point, I thought maybe I need to do like everyone else is doing, So because this is the most recommended combination. So you all know about this combination. The mixture of 50% autogenous bone, 50% xenograft. This is the most universal, recommended by so many people, starting from Philip Boyne in the 90s until Simeon, Boozer, Istvan, everyone. So this is the gold standard now. And I thought maybe it's good to mix with my allograft that I like so much. I want to mix something with it to make it more stable. And I decided to do the same, to follow the same recipe, mix some bovine bone with it. I started doing 50-50, and now my recipe, after 13 years, is to use 2/3 of this anchor or similar, and with some bovine bone. That's my recipe for now. So I've substituted the autogenous bone in the formula with this allograft. And that's my new magical potion, magical recipe. And look at that. So here I'm using the sausage, but not the regular East Van Urban sausage. This is a different type of sausage where I'm using a cross-link membrane, and precisely here, the RTM. I'm using not autogenous bone and xenograft. I'm using anchor type allograft with some xenograft. I'm using tenting screws because tenting screws are very important if you're using collagen. So this case, if I want to approach this case, I would say I use PTFE here because, like we've discussed it at the beginning, when you have a challenging defect, especially when you need to build both on the buccal and on the lingual and vertical, so it has to be a PTFE. Unless you're really in control, unless you know what you're doing, unless you know that your approach with collagen is very predictable. And that's my case now. Cases like that, I can substitute the use of a PTFE, titanium reinforced membrane, with a sausage, but not any sausage, with a reverse sausage where I did a sinus graft here. I put tenting screws both on the buccal and on the lingual, so barely 2 millimeter. Remember, the average with collagen is anywhere between, let's say, 2 to 5. So we're starting with a 1.5 millimeter ridge. If I gain 4, I'm still short. I still need even more. So here I'm just pushing the limit. I'm building both on both sides, and I'm stretching the limit. I'm aiming at 10 millimeter ridge, starting from a 1 millimeter ridge with a collagen membrane. So I did both the sinus and the ridge. That's the mixture. My Anchor style allograft with some bovine bone. And I covered everything with a cross-link membrane. And I trust it has to be a cross-link membrane. I did not do any comparative clinical trial. We started one at the COVID. I did one protocol with one of my students because I teach at the university. We had COVID and we barely had like six cases, like 3 versus 3. 3 BioGuide and 3 RTM, and we published it as a pilot study. But the difference was huge. So with the RTM, we had maintained practically like the bulk of the volume, and everything turned into bone. But with the BioGuide membrane, we lost around 60%, and hopefully soon, or in the coming year, we're going to be able to have a bigger sample. We're doing the cases. We'll be able to publish and give some evidence. So there is no comparative evidence between the cross-link and the non-cross-link. And this is serious because people have been using both for 20, 30 years, and there is no evidence. There is no comparative clinical data, like serious one. So, and I was able to get my 9 to 10 millimeter ridge, 9 to 10 millimeter ridge. So with this graft combination, with this membrane, with what I like to call the reverse sausage technique. So you see, I have the implant and I have like 2 and 3 millimeters on each side. That gives me enough safety, enough bone volume for the years to come. So I'm putting this case here to show the importance of tenting screws, because this case is very revealing. Because I know some clinicians, they don't think tent screws are of any help. And I personally think that tenting screws are of very, very good importance. Look at this case. It's revealing by itself, by the bare look at it. So you just need to look at it, and you can tell, you can understand that at the position where we have the 10 screws, we have a better width. So look at the third picture, the fourth one. So exactly at the position of the 10 screws, we have like 9 to 10 millimeter of width. In the pontic area, in the middle, we have less. So that means that 10 screws are important. So that's why in my reverse sausage technique, 10 screws are an important element. It's not only that cross-linking instead of native, it's not that only allograft instead of xenograft, and also you need to add 10 screws if you want to optimize your GBR using a collagen membrane. So look at this picture. This is a sideways view. It just shows the bone. It's like a cone, like a volcano around the tenting screws. It shows that where the tent screw is, we have bone. So, and now I need to show you some like difficult cases, aesthetic cases. So again, I've showed you that with the PTFE, with the cross-linked collagen membrane, and only with the allograft, not with autogenous bone, you can have a very good result. But still, you have to keep in mind that it still is not 100% predictable. The only predictable type of membrane, the only way to guarantee your outcome is to use a PTFE. You should never forget about the PTFE. Especially in cases like that. This is an aesthetic case, so highly plain. We lost those 2 teeth due to root resorption, periodontitis. We cleaned the patient, instructed her to hygiene, and that's the defect. It's a big defect in the middle of her face. So if you want to optimize your outcome, you don't use collagen here. You use PTFE, and so we have around 5 millimeter of vertical bone loss. So it's a 3D, definitely a 3D ridge defect. So the choice here falls back to PTFE. So, but in terms of graft, it's exactly the same graft, because this graft is very predictable. This combination is very predictable. The Anchor 7030 with some xenograft. I trust this combination very much. So, and that's completely reformed. And you see that this angle is very difficult to create this angle with the collagen membrane. So if you want to like support the aesthetics, support the soft tissue, support the lip, and have a nice ridge reformation, use PTFE. You don't use collagen. You don't use blocks. You don't use Khoury technique, because if you use Khoury technique, you would need probably a lot of soft tissue interventions to compensate, because with the Khoury technique, they never show you this angle. So this sideways angle, where this occlusal buccal angle is completely reformed, this is very difficult to get in any other technique beside the GBR. So I don't need to go through the video, it's not important. So the two implants were placed, some soft tissue procedures. So you see the bone is able to grow over the implant. This is abutment connection. So when you put an implant in a grafted site and you come back after 3 months and you see that a new bone has formed on top of those implants. And those implants that you have placed 3 months back, now they're buried, completely buried under the bone. That means that this bone is living. It's a living organ. This is well alive. You don't need to do histology. This is not just a magma of granulation tissue and particles, like so many people accuse the GBR technique of being like a mix of granulation tissue and some bovine bone. It's not the case. So this is a living bone. And you can see I'm gonna be swift with the prosthetic part. It's not important. I just wanna show you. This is a very nicely reconstructed case. And I want to show you the x-rays. Gonna be quick. A lot of pictures here. Excuse me for that. So this is at 6 years. And this is at 12 years. This is a 12-year follow-up. Look at the stability of bone around those implants. This is perfectly stable. So I'm going to show you some vertical augmentation of the posterior mandible, because you know the limits are like roughly, the literature is a little bit confusing, but roughly, take it roughly like 4 to 5 in all directions, 4 to 5, even vertical also. So, and there is some wisdom, some guidelines that were put forth by Simeon like 20 years back. If you want to go vertical beyond a couple of millimeters, you would definitely need autogenous bone, because otherwise the cells, they don't have the capacity, they don't have the biological potential to grow in a vertical, to climb the wall and go vertically more than 3 to 4 or 2 to 3. So I'm going to show you a case where I was able to build in a vertical dimension without any autogenous bone, 6 millimeters of vertical bone augmentation. So look at this. So we barely have a 2 or 3 millimeter above the nerve. And this is a landmark. So that's the tenting screw showing the mark of 6 millimeter on the probe. And this is the occlusal view, the same exact surgery, the same bone graft, the same membrane. It should be a PTFE here, nothing else. So now if someone might ask me, what about the RPM, the newly developed membrane by Osteogenics? This is a great membrane, but probably it works perfectly well if you have an autogenous bone underneath, because autogenous bone is quick, probably it's quicker than this graft. But this graft needs more seclusion, needs more protection. That's why I still did not shift to the RPM. I'm still using this type of membrane, the complete occlusion. So look at that. So we had formation, and I want you to have a close look at the aspect of the ridge. How much granules do we have? We have a lot of granules. It doesn't look nice, probably, to some of you. You might think this is too granular. Where's the bone here? But the bone is there. And sometimes even the volume, the newly reconstructed volume is a little bit moving. I'm going to show you. If you put some pressure on it, so the ridge is nicely formed, but how much bone do we have? So I've placed the implants and I took a histology. And I want you to see this. You see the bone is moving, I'm putting pressure with my probe, and part of this newly reconstructed bone is like moving a little. And probably to some of you, okay, so this bone graft is not good in these cases. But I invite you to wait a little And look at this case after 3 to 4 months. After, say, 5 months here, you need to be patient. Look at the complete corticalization. So this volume that was a little shaky. So because this is vertical, this is 6 to 7 millimeter in the vertical dimension. This is a 3D complete reconstruction. Everything has consolidated. Everything became like rock solid. So you see, I'm putting the probe and I'm exerting, I'm putting my weight against this probe, and it's not going in, it's not penetrating this new bone, and this bone is completely hard. So this was at implant placement, and this is at abutment connection. And if you think this aspect of bone that is moving is exclusive to the biomaterials, you're mistaken, because I've never stopped using autogenous bone just out of curiosity to keep like comparing for myself. And I have a lot of cases, I don't have time to show you here, where I have used autogenous bone 50-50 with xenograft, and I have exactly the same movement on the surface that will consolidate after a while. So I'm not seeing any difference between this graft combination and the autogenous bone. So look at the implant placed, and this was 2016. I had to follow up the patient for 4 years. You see, so these implants were placed completely in newly regenerated bone. And look at the stability over 4 years. Unfortunately, I lost track. I lost follow up with the patient. She's still there. She's still living, kicking and living, but she's not coming. I don't know why. I need to catch her one day. So this is perfectly stable. And I invite you to have a look at the histology. This is a similar case, 7 millimeter of vertical with this exact graft combination. And we have a very high percentage of newly formed bone inside this shaky sometimes bone graft. So let's look into some cases. I still have a minute to go. This is a case in the maxilla. Look at the potential, because when you're building vertically, you need to at least some ground zero, some base layer, some foundation of bone to build on it at least. In this case, we have built vertically in a place where we have zero. We have zero bone at the base because we had the communication here between the sinus and the oral cavity, and we had no bone. So I had to separate everything, separate the sinus from the oral cavity, and I had to that's the sinus here. I've lifted the sinus, and I'm building vertically, like 6-7 millimeter of vertical ridge augmentation over a site where simultaneously I'm doing a sinus elevation. And so this is 7 millimeter, as you can see. Same graft, same membrane, same outcome. And look at that. I left it to here for a year, but I've managed to create 7 millimeter of vertical, complete bone deformation, 14 millimeter of width. And I'm gonna be quick also to show you extreme cases, like extremely atrophic maxilla. So the extremely atrophic maxilla is like a chapter on its own in dentistry. So either you treat it with zygoma, or you take your patient to the hospital, you look for one osteotomy, you put some bone graft from the hips. So this patient in particular, she was at a maxillofacial surgeon, and they wanted to take her to the hospital to take some bone from the head, from the calvaria. So I told her, I can treat your case with a GBR, with the biomaterials, with a membrane. You don't need to do any hospital surgery. And I did it like that. So I did sinus lift and GBR at the same time. I'm gonna be quick. So sinus grafting, that's reverse sausage technique. And I put some implants for immediate temporization to be able to temporize the patient and give her something to eat. So those implants, even if I lose them later, they're barely holding here at the corners. And after a while, after a month, a year and 2 months, that's the amount of bone that we were able to regenerate. Plenty of bone. Bone is all over, and everything is hard. And the test, again, the probe. So I put the probe against this bone, and I put my weight against the probe, and it's not going in because the bone is completely solid. And remember, no autogenous bone was used here. and now she's been functioning. I'm not gonna go into the soft tissue procedure. She's been maybe over, it's been 10 years. So I finish with this case because, you know, GBR has evolved from a treatment to treat decent type defect, extraction sockets, like bigger cases, vertical, 3D, and what about cleft lips and palate? So they were never like really addressed, except some case reports, and even those cases like complete bridging, complete discontinuity defect. I bridged that without any autogenous bone. So this is one example. So the surgery from a soft tissue perspective is difficult. You need to remove the cleft area and mobilize big flap to be able to cover. So also on the palatal aspect, but it's not the core of the subject. The idea is that you bridge discontinuity defect without any autogenous bone by using exclusively the anchor type graft with the with some xenograft, and that's the case. And I invite you to have a look here around the green circle. Again, I'm putting the probe and I'm putting all the pressure. Nothing is going in. We have complete bone formation, complete density. And I thank you for your attention. And I don't need to ask the question again, is autogenous bone absolutely needed? And I guess not. So we still have a lot to do to prove. I mean, in a scientific way, in a clinical trial setting at the histological level, but this is only a personal experience, nothing more. But this is something I'm really trusting now, and I've been doing it for more than 10 years. And thank you.
Thank you, Dr. Samarani. Beautiful cases, great presentation as always. Appreciate you sharing with us. We do have some time for some questions, and we had several roll in, and I think they're all insightful. So I'll ask you the questions, and then you can provide some insight. So on all these cases, I mean, it appears that you gained primary closure. Just can you speak around primary closure? Is primary closure always necessary? Do you always are you always trying to gain primary closure in these large cases?
Yeah, in these large cases, I always attempt to do a primary closure. A tight one so I do flap advancement. I always do flap advancement because I know this question is coming from the perspective of socket preservation, because the cytoplast technique, we have the socket preservation approach where intentionally we don't close over the membrane, and we still have bone. This is completely different, because if you want to have a good bone volume, prevent infection, prevent complications, optimize the outcome, you have to close here. And it's coming also, there's a Japanese dentist who published a series of cases about the open membrane technique for treating ridge deficiencies. I'm well aware of his work, and I've looked into it, and one of my colleagues, he liked this approach, and we keep comparing results. And I think if you want to optimize the volume, you need to close. If you're okay in losing maybe 20 or 30% or 40% of the volume that you have grafted, you can do this approach. Like do a minimal flap reflection, put your bone graft and put the PTFE membrane without the intention of closing, and keep it exposed for a while, and then remove it after some weeks and hope a secondary intention healing. This is possible, but in small cases, but still you're gonna lose a big amount of volume. So if you're fine with that, I think you can do this approach. But in those cases where you want to optimize everything, you should always attempt the primary intention closure.
Great. The decortication of the bone. You showed a lot of your cases. You are decorticating the cortical bone before you place your bone graft. What are your thoughts around that?
Yeah, I do it because I know there is no evidence that decortication provides superior results, but in the doubt, I do it.
Very good. What about it's a question specifically for do you have any experience or use Gym 21, which is a recombinant um,
Yeah.
growth factor? But so I'd say speak to Gym 21 or any growth factors. Are you using any right now in any of your cases?
I don't have any experience with the growth factors. They're not available in where I practice, so I don't. But I'm following up the literature a little, and I think Gem 21 might be justified in really, really big cases because, as you can see, in the cases where your deficiency is 1, 2, 3, 4, 5 millimeters in any direction, you can manage without the Gem 21. You can manage. Probably in those cases where you have like a big, huge defect, probably it's justified there. The cost is justified. And moreover, we don't have enough data, enough clinical data, enough follow-up about the stability of this newly formed bone. And there is one thing that I don't really appreciate with Gem 21 is the fact that you need to use a tie mesh or something that is open to have the communication with the periosteum. So with this approach, you're going to have some soft tissue invasion and you're going to lose part of this volume underneath the membrane. So my intent always is to optimize. So I want to turn everything that is underneath this 10, I want to turn it into bone because especially in the posterior mandible, for example, because sometimes you have barely 3 or 4 millimeters above the nerve and you're building vertically, but still your limit is the adjacent peak of bone. Your limit is 3 to 4 or 5. So you're able maybe to reach 9 millimeter. And if you want to put your implant like 1 or 2 millimeters subcrestal to account for the bone remodeling, and you need to stay at least 1 or 2 millimeter away from the nerve to prevent nerve damage, you're going to end up putting an implant of 4 millimeters. So if in those cases I use a Gem 21, I put a customized tie mesh. It's costing me a lot of money. Uh, uh, it's taking a lot of time to customize and to create and to do. And then I put this open structure. I get some bone probably inside, but I also have a very thick type of periosteum. And indeed, there's a paper by an Italian guy, Alessandro Cucchi. So he did an interesting comparison between when you use those open structures, whether he did two papers actually, whether the tie mesh or anything that is open versus a complete PTFE that is completely closed. And the pseudoperiosteum, this fibrous tissue layer, is much less when you have complete closure. So that's my preference.
Gotcha. Perfect. Got time for one more question here. See here. So when you're using xenografts, Osteogenics sells a porcine xenograft. There's also a lot of bovine xenografts out there on the market. Do you have any experience between a porcine and a bovine? Do you have a preference one over the other? Just thoughts around that.
Yeah, I can only have thoughts because it's very difficult to prove that one is better. But I like the fact, for example, the Z core, the porcine from Osteogenics, I like the fact that it has a lot of porosity because it's very important to keep some space in this regenerated volume, to keep room for vessels, for new bone to form. Because anyhow, the role of the xenograft is like a scaffold to help to conduct bone formation and to act a little bit against the excessive remodeling, the excessive osteoclastic activity, which both do. So that's my opinion.
Understood. Well, great. Well, we'll end it there. I want to remind everybody once again that you'll be receiving a survey via email shortly after we log off here. Once you fill out that survey, we will email you your CE certificate. So be on the lookout for that. And with that, Dr. Samarani, thank you again. Look forward to doing more things like this with you in the future. And hope you have a good evening.
It's always a pleasure. Thanks.